Georgia, 5 minutes for your questions, please.
Thank you, Mr. Chairman, and thank all of you for being here. Mr. Chairman, I want to thank you for holding this hearing today and for including the discussion on the gag clause legislation. It is something that is very important and something that I have stressed since I've been in Congress, and something that is important to patients. I think that's the point that I'd like to get across most, is that this is something that is really hurting patients more than it's hurting anyone. Mr. Chancey, I want to thank you for being here. I appreciate it very much. I know you've traveled a long ways, as a lot of you have, but I wanted to ask you, Mr. Chancey, examples of gag clauses. Now, I think everybody by this point understands what we're talking about when we're talking about gag clauses, but have you actually seen a contract that had the language in there that and perhaps it wasn't written the way that you would understand it, but have you ever seen a contract like that?
First of all, it's very difficult for us to even get our hands on these contracts, and they change frequently. So I have not seen anything that even stated that it was a gag clause.
Right. But just because it's not stated, there are other ways that the pharmacy benefit managers can get at this. You mentioned earlier about CVS Caremark. CVS, of course, is a competitor, national chain, I believe the largest drug chain in America. And yet Caremark, one of the top 3 PBMs in America, it's the same company. You can make an argument that the Caremark owns CVS or CVS owns Caremark. It doesn't matter. They're the same thing, but there are other ways. You ever get audited by any of these groups?
Yes, we do. One of our stores is next door to a CVS, and they do audit us.
So actually, you've got a contract with a PBM that has a drugstore right next to you, and you're getting audited by that PBM that owns that drugstore right next to you. Do you find that somewhat intimidating, if you will?
Yes, and it's challenging at times.
I can imagine. I wanted to ask you, in your written testimony, you gave some examples of where you had actually told some patients about this, and I believe there was one example with a mayor of one of the municipalities around. Can you share that very quickly?
Yeah, that's correct. He came in, and his prescription came to be $26, and they had just changed insurance plans. And, we told him that if you paid cash for this, it would be cheaper. And he said, I don't understand. I want to use my insurance. And I said, well, our cash price is $8, but if we use your insurance, we have to charge you $26, because the PBM was actually taking $24 back from us. Anyway, the point was, out of pocket was $8 for him. Using his insurance, he had to pay $26.
Mm-hmm. So this point was brought up. I believe, Dr. Yoder, you may have brought it up, and it is a valid point that, if you don't use your insurance, it's not going to go toward your deductible. Do you, Mr. Chancey, do you have an opportunity to know how close a patient is to their deductible? Is that any kind of information that you're privy to as a pharmacist?
No, we don't. The only way we find that out is if we bill it through their insurance and we find out that they have met their deductible or they haven't. So
right.
we fill prescriptions or process prescriptions until we get to that point.
But if we were realistic about this, the example that that Representative Dingell just gave, now that would have been $1,300 going toward a deductible. She made the choice to pay the $40, which obviously I think most of us would have. But the other example that you gave, where it was $7 as compared to $26, that's not really going to impact the deductible that much, is it?
Oh, no, not at all.
I don't think it's going to help them get there. So with all due respect, Dr. Yoder, that's the point we're trying to make here. Generally, it's, that's an extreme case, and that's exactly what we're talking about. I mean, that's nothing short of ridiculous, and we all understand that. One other point that was made by Dr. Yoder was the fact that if you don't get it filled through the insurance company, that you may not see a drug interaction. But is it true, Mr. Chancey, that most pharmacies now have programs where drug interactions are before you fill a prescription, you're going through the patient's profile and looking at all the drugs that are on there anyway?
That's correct.
Okay, so it really should not be that much of a problem, unless they're getting it somewhere else, which could happen. But for the most part, you find your patients to be getting their medications at one drugstore.
That's correct.
Okay. Boy, 5 minutes flies when you've been waiting around all day to get asked questions. I do want to thank all of you for being here, and this is something that's very important. And again, Mr. Chairman, I want to thank you for this discussion and this hearing today. Very important. I could not agree with you more that this is the most important subcommittee in Congress. So thank you, and I yield back.
And the most productive.